All right, I call our meeting to order, and I want to welcome our guests. I want to welcome Ms. Kwan as the replacement for Don Davies. I want to thank our Vice Chair for chairing the last couple of meetings and appreciate your cooperation there. And I also want to thank you for tabling that petition yesterday in the interest of seniors. Yeah, okay. All right, well, now we're going to continue our study on opiates and the opioid crisis. And we have some guests this morning. They're going to make presentations. And how long is the opening presentation? 10 minutes. 10 minutes? Okay, we have each party has 10 minutes as an opening statement, and then we'll switch to questions. So first of all, I'm going to introduce the Canadian Medical Association, Dr. Jeff Blackmer, Vice President of Medical Professionalism. And we also have the Canadian Paramedics Association. The Canadian Pharmacists Association, Alistair Bursay, Chair of the Board. And we have Régin Leclerc, the President of the Montreal Laval Paramedics Association. I want to thank you all for coming. We have the Vancouver Firefighters Union, Local 18. Chris Coleman is a firefighter, and Lee Lax is a firefighter. So thank you very much for coming. We'll start with the Canadian Medical Association. You have 10 minutes.
Thank you, Mr. Chair. I'm Dr. Jeff Blackmer, the Vice President of Medical Professionalism for the Canadian Medical Association. On behalf of the CMA, I would first like to commend the committee for initiating this emergency study of the public health crisis in Canada. As the national organization representing over 83,000 Canadian doctors, the CMA has an instrumental role in collaborating with other healthcare stakeholders, governments, and patient organizations in addressing the opioid crisis in our country. On behalf of Canada's doctors, the CMA is deeply concerned with the escalating public health crisis related to problematic opioid and fentanyl use. Physicians are on the front lines of this epidemic in many respects. We are responsible for supporting patients with the management of acute and chronic pain, and policymakers must also recognize that prescription opioids are an essential tool in the alleviation of this pain and suffering, especially in palliative and cancer care. The CMA has for a long time been concerned with the harms associated with opioid use. We appeared before this committee as part of its 2013 study on the government's role in addressing prescription drug abuse. At the time, we made a number of recommendations on the potential role of government, some of which I will reiterate for the committee today. Since then, the CMA has also taken a number of actions to contribute to Canada's response to the opioid crisis. These actions have included advancing the physician perspective in all active government consultations. In addition to the 2013 study by the Health Committee, we have also participated in the 2014 Ministerial Roundtable and recent regulatory consultations led by Health Canada. Specifically, we have contributed input on tamper-resistant technology for drugs and the delisting of naloxone for the prevention of overdose deaths in the community. Other actions that we've undertaken have included undertaking physician polling to better understand their experiences with prescribing opioids, developing and disseminating a new policy on addressing the harms associated with opioids and other prescription medications, supporting the development of continuing medical education resources and tools for physicians, supporting the National Prescription Drug Drop-Off Days, and hosting a physician education session as part of our annual meeting in 2015. I'm also pleased to report that the CMA has recently joined the Executive Council of the first Do No Harm strategy, which, as you know, is coordinated by the Canadian Centre on Substance Abuse. In addition, we have joined 7 leading stakeholders as part of a consortium formed this year to collaborate on addressing the issue from a medical and clinical standpoint. It's important for the committee to recognize that inappropriate prescribing of opioids is not the sole contributing factor to our current crisis, and that targeting this issue alone will not lead to a resolution of the problem. However, physicians must accept our share of the responsibility, and we are prepared to play our part in doing what is necessary to move forward in addressing this very complex and multifaceted problem. I'll now turn briefly to the CMA's recommendations for the committee's consideration, and these are grouped into 4 major theme areas. The first of them is harm reduction. Addiction needs to be recognized and treated as a serious chronic and relapsing medical condition for which there are effective current treatments. Despite the fact that there is broad recognition that we are in a public health crisis, the focus of the federal national anti-drug strategy is still heavily skewed towards a criminal justice approach rather than a public health approach. In its current form, the strategy does not adequately address the determinants of drug use, treat addictions, or reduce the harms associated with drug use. The CMA strongly recommends that the federal government review the national anti-drug strategy and reinstate harm reduction as a core pillar of this strategy. Supervised consumption sites are an important part of a harm reduction program that must be considered as part of an overall strategy to address the harms associated with opioid use. The availability of supervised consumption sites, as you know, is still highly limited in Canada. The CMA maintains its concerns that the new criteria established by the Respect for Communities Act are overly burdensome and deter the establishment of new sites. And we continue to recommend that the Act be repealed or at least significantly amended to address this issue. The second theme area I will raise is the need to expand treatment options and services. Treatment options and services for both addiction as well as pain management are very under-resourced in Canada. This includes substitution treatment such as Suboxone and Methadone, as well as services that help patients taper off opioids or counsel them with interventions such as cognitive behavioral therapy. Availability and access of these resources varies significantly by jurisdiction and region, and the federal government has a role to play in prioritizing the expansion of these services across the country. The CMA recommends that the federal government deliver additional funding on an emergency basis to significantly expand the availability and access to addiction treatment as well as pain management programs. The third theme I will raise for the committee's consideration is the need for greater investment in both prescriber as well as patient education resources. For prescribers, this includes continuing education modules as well as training curricula at all levels of the medical continuum. We need to ensure the availability of unbiased and evidence-based educational programs in opioid prescribing, pain management, and in the management of addictions. Furthermore, support for the development of educational tools and resources based on the new clinical guidelines that will be released early next year will play a very important role in the overall approach. Finally, patient and public education on the harms associated with opioid usage is critical, and as such, the CMA recommends that the federal government deliver new funding to support the availability and provision of education and training resources, not just for prescribers, but for patients and the public as well. Finally, to support optimal prescribing, it's critical that prescribers be provided with access to a real-time prescription monitoring program. Such a program would allow physicians to review a patient's prescription history from multiple health services at the point of care prior to prescribing medications. Real-time prescription monitoring is currently only available in 2 jurisdictions in Canada. Before closing, I should emphasize that the negative impacts associated with prescription opioids represent a complex issue that will require a multifaceted, multi-stakeholder response. A key challenge for public policymakers and prescribers is to mitigate the harms associated with prescription opioid use without negatively affecting patient access to the appropriate treatment for their clinical conditions. As one CMA past president said, the unfortunate reality is that there is no silver bullet solution and no one group or government can address this issue alone. The physicians of Canada are committed to being a part of this solution. Thank you very much.
Thank you. Now we'll go to the Canadian Pharmacists Association, and I missed Dr. Emberley on my introduction, so I apologize for that, but go ahead, Canadian Pharmacists.
Good morning, everyone, and thank you for the opportunity to be here today. My name is Alistair Bursey, and I'm a community pharmacist from Fredericton, New Brunswick. Bonjour, je m'appelle Alistair Bursey, et je suis...
Good morning, my name is Alistair Bursey. I'm from New Brunswick.
Addiction in our communities, from the perspective of a practitioner at the front lines of an urgent public health crisis. I'm also the chair of the Canadian Pharmacists Association, the CPHA, which is the national voice of Canada's 40,000 pharmacists. I'm joined today by my colleague Phil Emberley, who serves as CPHA's Director of Professional Affairs and also works as a community pharmacist here in Ottawa. I want to begin by thanking the members of this committee for convening this emergency study. There's no question that opioid abuse is fast becoming a Canadian epidemic, and we need strong leadership in this country to stem the tide. Phil and I can tell you that not only are pharmacists the experts when it comes to medication, but that we serve on the front lines in our communities. Every day in our practices, we come face to face with the tragedy of opioid abuse. As a pharmacist, my mission is to treat all patients in my community. Over the years, the number of patients receiving addiction therapy in my practice has grown at an unsettling pace. Generation after generation are caught in the grips of addiction, and often we see them years after the damage has already been done. We know this problem can't be solved overnight, but there are many things we can do to treat those affected, prevent inappropriate prescribing and dispensing, and to protect youth from the grips of addiction. Prevention is where I'd like to begin my remarks today. In addition to tackling the existing crisis, we really have to look at some of the underlying causes which have led us to this point. All levels of government need to work together to take a proactive approach to help prevent opioid misuse early on before it becomes a problem. This must be done through a mix of policies and public awareness of the consequences of opioid misuse and inappropriate use of pain medications. A particular focus should be on educating Canadian youth, as the evidence demonstrates that many young people are exposed to illegal narcotics before they graduate from high school. A key to success lies in building effective partnerships with healthcare providers. Community pharmacists play an important role in educating patients about the harms associated with prescription opioids and other potentially harmful medications. For example, medication reviews allow pharmacists to review the patient's response to their medications. This service provides an opportunity to educate patients on how to take their pain medications safely and can also flag drug-seeking behavior. Medication reviews can also reveal patient misconceptions about how and when to take medication, flag medications that are not adequately controlling pain, and confer whether prescribed to optimize pain therapy. This valuable interaction between pharmacists and the patient is vital to ensuring safe and optimal use of medications. The fact that we see each Canadian on average 14 times per year provides us a great opportunity to intervene with our expertise, to consult with family physicians, to improve patient pain control. CPHA supports the government's recent announcement that will proceed with regulatory change requiring opioids to carry warning stickers and come with patient information sheets describing addiction and overdose risks. It's a good start, but pamphlets and warning labels are no substitute for pharmacist care. That's why CPHA recommends that all jurisdictions, including the federal government as a provider of health services, expand funding for pharmacist services to include pharmacist pain medication reviews. Funding pharmacist consultation and follow-up would go a long way to improving the outcomes of these patients. Education goes hand in hand with better prescribing practices. The government has acknowledged more must be done to support better prescribing of opioids, but Canada has fallen behind. We know that outdated Canadian prescribing guidelines simply do not reflect the best available evidence, yet our standards have not caught up. While new guidelines are expected next year, prescribers may feel pressured to prescribe opioids to patients experiencing acute or chronic pain without trying non-drug approaches. In the United States, the Center for Disease Control encouraged prescribers to start patients with low doses while providing a limited supply. We must immediately adopt comparable standards here in Canada and ensure patients receive the best possible care. Prescribing guidelines are not the only thing that must change in order for our profession to be more effective in decreasing the inappropriate use of opioid medications. Pharmacy is the safest, most effective, and efficient and accountable delivery model for dispensing prescription drugs. But pharmacists can only be as effective as the tools at their disposal. The existing patchwork of prescription monitoring programs, also known as PMP, across Canada is no match for the problem of polypharmacy and double doctoring. PMPs are a stopgap solution. Moving beyond prescription monitoring to implementing a fully integrated drug information system, or DIS, and functional electronic health records, also known as EHRs, in every province and territory will ensure the pharmacists and physicians have access to the information they need to work collaboratively to monitor inappropriate prescribing and address drug-seeking behavior. Greater accountability will result when prescribers are unable to claim that they were unaware that a patient was being treated by another physician. The progress of deploying EHR and DIS across the country needs to be accelerated to give us the tools we need to reduce opioid addiction. Public drug plans can also help limit the supply of prescription opioids by limiting the number of opioid doses that can be reimbursed within a specific time period. In my home province of New Brunswick, opioids and other controlled drugs have been limited to a maximum 35-day supply for over 20 years. yet similar controls are not in place across the country. Limiting the maximum supply provides pharmacists with more frequent opportunities for monitoring and intervention and a much tighter turnaround time to engage the prescriber if required. From a public safety perspective, limiting the maximum supply results in a decreased inventory of narcotics in our communities. I know from my own experience that pain and chemotherapy patients have been violently targeted by criminals for their prescription opioids. Dispensing fewer capsules at a time can help reduce the risk of diversion. However, limiting diversion of prescription opioids from pharmacies is a drop in the bucket in fighting this public health crisis. Counterfeit pharmaceuticals manufactured illegally in clandestine labs are fueling the overdose epidemic, plain and simple. These drugs are highly dangerous, putting users at high risk of overdose since it's impossible to know what or how much of a given substance they contain. Illicit manufacturing of synthetic opioids like fentanyl is increasingly common, and law enforcement needs tools at its disposal to curb the growing supply. The government has made good progress through the restriction of precursor chemicals, but more can be done to limit production of these dangerous drugs. The Canadian Chiefs of Police report that criminals are importing commercial pill presses into Canada, but that border agents don't have the authority to seize them. To put this in perspective, these machines can be purchased online for less than $10,000 and can make between 10,000 and 18,000 pills per hour. As a pharmacist, I can tell you that there is simply no reason for an individual to be in possession of one of these machines. CPHA strongly urges the government to impose penalties for those illegal importation of pill presses and tablet machines, and to limit possession to pharmacists and others holding an appropriate license. Finally, we can't forget the human face of opioid abuse, and we can't turn our backs on people who have already succumbed to opioid abuse. We need more programs to help those who are currently addicted to opioids. Pharmacists play a frontline role in assisting recovering addicts by dispensing drugs to treat addiction, such as methadone, Suboxone, and naloxone, providing regular support, monitoring, and follow-up, sometimes on a daily basis. These programs and the health providers who deliver them need more support. There's no magic bullet to put an end to a crisis decades in the making, but we also want to be careful of unintended consequences. As we start to restrict the legal access to these drugs, frontline healthcare workers can be put at risk. Pharmacists will be the first to experience intimidation, threats, and unfortunately robberies. Recently, I was in discussion with a colleague from Newfoundland, where oil workers returning from Alberta to their rural communities in the throes of addiction have robbed pharmacies with gallons of gasoline and a lighter. Pharmacists are very concerned with the challenges that we're going to face as the supply tightens. Lawmakers, regulators, and healthcare professionals must work cooperatively to find solutions to stem the tide of addiction. Pharmacists are committed to being a major part of the solution, and we ask for this committee's support in combating opioid abuse in Canada. Thank you.
And thank you very much. And speaking of frontline workers, now we have Mr. Leclerc. You're up.
Good morning to everyone. Thank you, Mr. Chair. Members of the committee, thank you for welcoming. I'm aware of the privilege that I've been given this opportunity to contribute somewhat to your study of the opioid crisis. My name is Réjeanne Leclerc. I've been a paramedic for more than 20 years, and I'm currently president of the Syndicat du Préhospitalier, representing 1,000 paramedics working at the Corporation d'Urgence Santé, which provides emergency ambulance services to the residents of Montreal and Laval. Urgence Santé is the only government organization providing ambulance services in Quebec that has an annual budget of approximately $130 million, and we report to the Minister of Health and Social Services. During fiscal year 2015-2016, the paramedics that we represent were given 315,575 assignments for a population of some $2.4 million living in a territory of 744 square kilometers. The corporation is one of the most important ambulance services in Canada. Although we've heard a lot of information out of the work done by your committee, we have noted that no one to date has described the situation in Quebec. However, although the crisis is not comparable for the time being to that experienced by certain other regions in Canada, we have noted an increase in opioid overdoses in Quebec. Indeed, according to the Institut National de Santé Publique in Quebec, the death rate attributable to intoxications related to medication and drug use has increased significantly since the early 200,000s. This increase primarily reflects an increase in fatal intoxications following consumption of opioids. From 2000 to 2012, 1,775 deaths were attributed to intoxication following the use of opioids in Quebec. That represents a rate of 2.97 deaths per 100,000. Moreover, in the summer of 2014, Montreal was at the heart of an epidemic of overdoses of street drugs. In a few weeks, there were 233 cases noted, and nearly 30 people died. You can read about this in the press. It should be noted that, according to the statistics of the Quebec health insurance system, between 2011 and 2015, the prescription of opioids grew by 29%, going from 1.9 million to 2.4 million prescriptions. The number of people who have received prescriptions has increased by 10%, for a total of 370,365 people in 2015. In light of this information, some could say that we have a crisis. Some say the opposite, but regardless of the case, it has to be acknowledged that we need to control and improve data collection in order to have a better idea of what's going on and respond better in real time. Moreover, it was drawn to our attention that initiatives are about to take place, whether we're talking about distributing naloxone kits to people who are at risk of overdose, the will to implement supervised injection centers, the creation of monitoring groups in order to collect better data, the will of the Quebec College of Doctors to perfect their investigative knowledge with respect to its members, and the significant reduction of will lead to the significant reduction of deaths due to opioid surdose. We need to reduce deaths amongst our citizens, and we as paramedics agree with these initiatives, but we also believe in Bill C-224, tabled by the member for Coquitlam, Port Coquitlam. We feel that the survival chances of a person who has overdosed would be better following the adoption of this law, and we feel that this bill needs to be adopted as quickly as possible. We all agree that paramedics provide essential care to the population. In Quebec, the responsibility for assessing and maintaining the quality of cases come under the Ministry of Health and Social Services. But there is no professional body which governs Quebec paramedics. The profession of a paramedic has not been officially recognized, and that's why Bill C-224, which provides for an exemption of drug possession charges for people who are the first to arrive, is necessary. Quebec people will not be able to benefit from this exemption until paramedics arrive at the scene of someone who has had an overdose. We must ask ourselves, it's very good, it's essential that we adapt Bill C-224 to bear this feature in mind. Furthermore, Mr. Chair, and I'd like to talk about another issue that's very of concern. Faced with the challenges regarding an increase in opioid overdose, we would like to express our concern about the way the Corporation d'Urgence Santé manages the training of paramedics with respect to the naloxone protocol. In November 2014, we had an opportunity to train paramedics. We made a suggestion in order to promote the rapid deployment of this antidote in Montreal and Laval. To our great surprise, the corporation did not follow up on our request because of budget restrictions, preferring to stick to their austerity measures imposed by the MSSS. The corporation decided, right when the opioid crisis was in full flight, to train a few dozen paramedics, with only 50 or so paramedics who are authorized to provide this precious medication. We realize that this is not adequate and we have already seen what's happened in an article written in the press. This was written by Dr. Marie Morin, who wondered what would happen when an ambulance was called to the scene, but that the paramedics were not given the proper training to provide the antidote and help the person who has overdosed. As an emergency service, what message are we sending to the people when the majority of paramedics are not able to take the necessary action in the case of an overdose? It could mean life or death. We need to adapt and change laws in order to encourage people to call 911 more quickly, but if the paramedic team is not qualified to take action in the case of an overdose, we're going to miss reaching this objective. Is the Montreal and Laval population better served today? According to data obtained by Radio-Canada from the Ministry of Health and Social Services last September, only 35% of these 1,000 paramedics have been trained to administer naloxone. This statistic is of concern to us and is incompatible with the efforts made by this committee. This unfortunate situation should be denounced, in our opinion, publicly until Urgence Santé paramedics are trained properly and are thereby able to administer naloxone in order to save lives. Thank you for your attention.
Okay, Vancouver Firefighters Union.
Thank you, Mr. Chair. I am a firefighter in Vancouver. I'm also chair of our political engagement committee for our union, Vancouver Firefighters International Association of Firefighters Local 18. The Vancouver firefighters appreciate this opportunity to share our views with you as you study the opioid crisis in Canada. We appreciate the committee's recognition of our role in responding to the crisis and its interest in hearing directly from firefighters as we all work towards a mutual goal of mitigating the consequences of the human tragedy that is unfolding in our city. Our union represents more than 760 full-time professional firefighters in the City of Vancouver, men and women who respond to virtually any emergency in minutes and who are the city's first line of defense. We're an all-hazard public safety service that's 100% municipally funded. Our members respond not only to fires where suppression and rescue of trapped citizens may be required, but also to medical emergencies where we administer first aid until paramedics arrive, to hazardous material incidents, to technical rescues, to ice and water rescues, and to any other kind of emergency. As witnessed in the past, and especially the past few months, Vancouver firefighters are on the front lines of the opioid crisis that is sweeping our city, especially the downtown east side, which, for lack of a better expression, is ground zero for this epidemic, which largely results from abuse of fentanyl and even stronger opioids. Only a few years ago, police and public health agencies were warning that fentanyl abuse was a growing problem in Canada. Today, they're warning that bionic opioids, 100 times stronger than fentanyl, are coursing through the streets, finding their way into the hands of everyone from hardened addicts to teens who are just looking to party on the weekend. Vancouver firefighters are seeing the devastating results of this firsthand. We're witnessing the tragic human toll of this crisis on a daily basis, dozens of times a day. The crisis is also taking a toll on the many agencies and workers on the front lines, including firefighters. And it's taking a toll on the resources that our department has available for the purpose of safely and effectively protecting the public from all emergencies. To put this problem in perspective, here are some numbers. I'm sure you've heard them, but please let me repeat. According to the BC Coroner's Office, the percentage of illicit drug deaths in which fentanyl is involved rose from 5% in 2012 to 30% in 2015 to 60% so far in 2016. This is moving in the wrong direction. In the first 8 months of this year, Vancouver firefighters responded to 2,287 overdose incidents, an average of 286 per month, though that number has spiked to 309 overdose incidents in July and 341 in August. The vast majority of these overdoses were in the catchment of Fire Hall 22 in the downtown east side, which earlier this month recorded over 1,000 emergency calls in a single month for the first time in our history, and it has remained at that extreme level ever since. In essence, our call volume has doubled since fentanyl has entered the picture. Emergency medical response is nothing new for Vancouver firefighters. We arrive quickly on the scene of medical emergencies and using existing personnel and vehicles to improve patient outcomes in a cost-effective manner. Adding the very effective opioid antidote naloxone and the appropriate training to firefighters' medical skills has made a huge difference in the current opioid crisis. Our medical role is also a great example of a value-added service that has a major benefit at relatively little cost. Our capacity to respond to medical emergencies such as opioid overdoses adds capacity to the existing provincially funded ambulance service. Our ability to respond quickly using existing fire department personnel and vehicles puts a trained professional on scene in a timely and cost-effective manner while freeing ambulance resources for other emergencies. But as our fire department resources become increasingly focused on one type of emergency within a 6-block area of the city, it can only be expected there will be impacts in other areas. Responding to the opioid crisis can tie up resources, which means fire apparatus may have to come from a nearby district in order to respond to other emergencies. This in turn can affect response times at a time when every second counts. Remarkably, despite booming construction and a sharp population growth, there are fewer frontline firefighters in Vancouver than there were 20 years ago. Our association is working hard at the local level to advocate for increased frontline resources, which are a key element of public and firefighter safety. Our role in responding to the opioid crisis has also meant there are fewer resources available for fire prevention work in the communities we serve. There's less time for the training we normally undergo on a regular basis to ensure we are skilled and prepared to do our jobs effectively. Another consequence of the opioid crisis is the toll it takes on all those who are on the front lines and who sees its results firsthand. Specifically, it takes a toll on an individual's mental health to see such helplessness and suffering up close on a daily basis. To work extremely hard, but to feel that you are having little or no impact on a problem that is growing exponentially like a tidal wave on the streets of your city. There is a mental strain in watching a population repeatedly harming itself and then ultimately witnessing death in deceased persons who have succumbed to this human tragedy. There's a physical and mental strain in the sheer volume of responses, which ultimately affects a firefighter's ability to recuperate between shifts. On this point, I feel I must be clear and I must stress that our brothers and sisters who work in the downtown east side are in trouble. They feel abandoned and they feel hopeless. And in conversations with these firefighters, I hear a lot of, "It's driving me nuts, I can't take it." They tell me, I'm told stories of being in an alley with 20 or 30 drug users. They're unprepared and untrained for that, and while dealing with an overdose patient who's rolling around in urine and feces and a needle in the neck, and this is not the first time they've dealt with this particular patient during that shift. And that's part of the hopelessness. They feel abandoned and they feel hopeless. It bears mention that while Vancouver may be ground zero for the fentanyl crisis, it is a national problem that's now taken root in cities across Canada. In Ontario, again, numbers I'm sure you've heard, 162 deaths were reported as fentanyl overdoses in 2015, and at least 32 deaths in Atlantic Canada, according to news reports. It is a national problem with provincial and also federal implications in that illicit opioids, such as the one wreaking havoc on my downtown east side, are typically shipped to Canada from other destinations as Asia, with Vancouver being an obvious port of entry. And as noted, our medical response eases the burden on the provincially funded ambulance system. Now, in that context, the committee should note that Vancouver Fire Rescue's role in responding to this opioid crisis is an example of a municipal government shouldering a cost that isn't borne solely at the municipal level, and that municipal and provincial requests for funding should be viewed through that lens when appropriate. The Vancouver Firefighters Union commends the work that various government and non-governmental agencies are doing in response to the opioid crisis. And we support current social initiatives that are designed to reduce harm, ease suffering, and otherwise assist those who are struggling due to the opioid crisis. I'd like to add there as well, I offer a unique perspective as not only am I a Vancouver fireman, I live in the downtown east side. And the people who choose to come down there to work with the severely addicted, mentally ill deserves our thanks, and that's what I'm doing. We, as Vancouver firefighters, are one of but many groups of dedicated people who are doing what they can to alleviate this crisis. Thank you again for undertaking this important study and for requesting the input of Vancouver firefighters. And I welcome any questions the committee members may have. Thank you.
Well, thanks very much, and I find it interesting. I think you've all thanked us for inviting you to make a presentation, but on behalf of the committee, I want to say thank you for coming and telling us your story and your experiences in this crisis, because few of us have had any experience at all like you have had, and we appreciate your input, and it's not falling on deaf ears. So we're going to start with 7-minute questions with Mr. Ayoub.
Merci, Monsieur le Président. Merci.
Thank you, Mr. Chair, and thank you all for coming. I would like to start by asking Mr. Clare a few questions. Thank you for coming here. The national situation is worrisome. The situation of Quebec concerns me a great deal. Further to your testimony, further to newspaper reports that have been written, how can you explain the fact that we don't look at the experience elsewhere in Canada, Vancouver's experience, but that in Quebec we don't manage to provide the necessary training? You mentioned this in your testimony, but I would like you to explain why in Montreal in particular it seems to be a disproportionate problem. Why don't we provide training? Could you please elaborate? I would say that essentially we are currently dealing with budget restrictions because Urgence Santé is a government body reporting to the Ministry of Health. The government has issued some budget restrictions, including the way we deal with opioids. There was a crisis back in 2014, if you will recall. We had concerns about the Ebola virus. We also were dealing at the same time with the opioid crisis. So a choice was made at that point. Who makes that type of choice? Urgence Santé together with the ministry. Because what you have to understand is that it was decided that the training would be put off. It was postponed. Later, when? I would say for 2019, 2020. Between now and 2020. And when the crisis occurred, just for appearance's sake, they thought that they should train a few paramedics, thinking that would cover the issue. But there has been a cutback now in training, and paramedics are not completely trained. Normally, it's a 4-hour training session, so it's going to take several months in order to train all the paramedics. In Quebec, when I look at the statistics and the training of paramedics, 70%, there were 3 exceptions for 3 regions. How do you explain those statistics? Even regions have not had complete training. That there was we were already lagging back with our mandatory training, so they had to ramp up the training. They did try and do so, but then the opioid crisis occurred, and the organization wasn't able to adapt because of the budget restrictions. How much time will it take for Montreal and Laval to catch up and provide training? Do you think it'll take 1 year, 2 years? It depends on the will of the authorities. I would say that starting from zero today and in 4 to 6 months, everybody could be trained, including I know that this isn't your area of expertise, but you work with other first responders, including firefighters, police officers. Would you be open to the suggestion that these services should be trained as well? What's important is that the medication gets used for the victim as quickly as possible. This drug can be given without a prescription, so it goes without saying that we do have to provide training. You have to know how to administer it, but you would be open to the fact that other services get the training. No, providing we save lives. Time is of the essence here. I don't like to presume things, but we've already got statistics. We know how many people have died because they have not had access to this drug in Montreal, because difficult to say. The coroner would have to investigate, to do a full study on this, to see the fact that the ambulance arrives not as quickly as it should, the fact that the medication is not given. I don't know. We need to do investigations, but I must say that paramedics are there on the scene. They've seen that the patient has overdosed, and they can't do anything about it because they're not trained. But I don't have accurate data about that. Thank you. We're looking at steps that the federal government could take in the health sector, and we're looking at health budgets. I'd like to quote from Mr. Yves, who is from the Canadian Medical Association. We're always dealing with budgets. How do you see the federal government stepping in this crisis? Because there are differences in planning procedures, in training procedures. This is both, things vary from one region to the next. So how do you see the federal government intervening to provide follow-up or helping to assist us with this national crisis? How can we ensure that right across the board we have uniform cares? I would use the example of the Ebola virus, the way the border services were involved. Everyone was involved. The instructions were clear. We asked for follow-up after the crisis. And in this particular case, the crisis varies from region to region. At first, the opioid crisis just was limited to Vancouver, but it spread. So I think we need clear instructions. There has to be follow-up, and we have to ensure that resources are put in the right place. We have to ensure that planning procedures can deal with this type of urgency, but things have to be clear. Right now, we talk about the crisis, but I don't see the employer or the ministry working to ensure that this crisis will be dealt with the same way we dealt with the Ebola viruses. So you would be in favor of the federal government trying to regulate, trying to provide directions to ensure that there is some uniformity across the country, regulations and orders. Express clear directions. That's very important. in order to deal with the situation. It's an area of public health. Regulations, I don't know. That's not my area of expertise. But you have to ensure that the instructions, directives are clear.
And good to see you back. I hope you're feeling much better. I want to take this opportunity to thank all the panelists and witnesses here today. This is a huge issue, and we really appreciate your input. I really like what the pharmacist said, Mr. Bursey said, that we really have to take a big picture approach to this it's about prevention. The solutions are about prevention and treatment. It seems that governments of all levels seem to want to focus on these short-term interventions. So I appreciate your input on that. I did want to start with the firefighters, though. I read an article recently about one of your members, Ryan McConnell, a Vancouver firefighter from Fire Hall 2, recently said, "Welcome to Welfare Wednesday in Vancouver." He was referring to the busiest day for firefighters because it's the day that people line up to get their monthly welfare checks. Jason Lynch, another Vancouver firefighter, said that he had to revive a 24-year-old girl twice in 1 month. And I think all of us realize, like, each person has such great potential in this great country of ours, but to hear stories like this, reviving a 24-year-old twice in 1 month, I think we have to say that we need to do more. And I do understand the importance of naloxone, on the ground, but I was going to ask you, is naloxone really the solution, or as Mr. Lynch stated, is it just a small Band-Aid on a big cut?
Thank you for the question. I'll introduce my colleague Lee Lax as well. It's a great point. Naloxone doesn't prevent overdoses. It doesn't fix the problem. And we could put, our chief tomorrow could put 100 more firefighters at the downtown east side. Doesn't change a thing.
No, and that's the thing. Like we can make naloxone available, but and it may be a temporary solution. But in my opinion, it's not the solution. And a concern out there too is now that people know, or addicts know, that this is more available. Do you see a concern that this is another way that addicts may start to feel invincible because if they know that that's available? Is this something, especially for young people who might be out there trying this for the first time, is that a problem we have to be aware of?
Well, I feel the problem is a health one. With or without the naloxone, somebody's got to get high. They need their body. They're addicts. And I think with or without naloxone, I don't think, this is just, living there and watching it and working there. No, I don't think so. I think the addict will continue to use because they have to use. I don't believe naloxone has made anyone more of a Superman. I mean, there's enormous risks before, the stronger drugs.
Well, and they seem to be getting stronger and stronger. My colleague just mentioned that there's a new one out 100 times more potent, super fentanyl out there. And I think we really kind of have to focus on prevention. We had Dr. David Jerlink from the Division of Clinical Pharmacology and Toxicology at Sunnybrook Health Science Center. He was here last week or the week before, and he put a lot of blame on physicians. He was pretty hard on physicians about lack of education in regards to prescribing, and more specifically the overprescribing of opioids in Canada. And I see it, though, physicians can only do so much. And maybe I can ask, I think Dr. Emberley, you're aware that the US FDA has now approved over 7 abuse-deterrent, tamper-resistant opioid formulations of prescription opioids from 4 different manufacturers, while our current Canadian government has abandoned this regulatory pathway, which was being pursued by the previous government. It was supported by our own provinces and territories and health ministers. I was wondering, does the Canadian Pharmacy Association support the use of abuse-deterrent, tamper-resistant opioids as one tactic in a part of a broader national opioid strategy, and if so, why? And the second one, would you support a regulatory move to convert the entire class of controlled release or all opioids to the ADF or tamper-resistant formulations over a short transition period?
Thank you for the question. We spoke out in favor of tamper-resistant formulations a few years ago, and one of the reasons was we had a very problematic drug, namely OxyContin, that was introduced in Canada that we all know created huge problems, and as a result of that, there was a tamper-resistant formulation, Oxyneo, that was developed. And so we saw this as a move forward. It was not the only solution, but it was one solution. So we got some signals from the U.S. that this was going to become a pattern for all new long-acting opioids to be introduced in this format, and we saw it as a good thing. And we are still positive about this technological innovation. However, the other side of it is that we've seen an unintended consequence that people have seemingly turned to illegal sources of narcotics and opiates. They've gone to the illicit market. We spoke about the fentanyl crisis with illicit forms of fentanyl being introduced. And what it creates is this whole concept of a balloon effect. If you reduce the attractiveness of one type of medication or formulation and in fact make all narcotics tamper resistant, it causes certain elements of our society to move to the illicit form. So we have to be very careful. So the short answer is yes, we still see tamper resistance as one solution, not the only solution, but as one solution. There are some numbers out of the U.S. that say that it has had some effect. But we have to be very, very cautious of the unintended consequences, which may end up being even worse than what we were trying to prevent in the first place.
Well, I think we are seeing now it appears like there's a certain percentage of it which is prescribing, but then a larger part of it seems to be this illegal fentanyl, like you mentioned, the pill presses and stuff like that. So I was going to ask Mr. Blackmer about it. Now, your organization is known and been working on this issue for the past decade. What have you done to help, like, work with colleges to educate and help improve the knowledge of physicians on the ground? Because I see tamper resistance as part of a tool, but on the ground, a 24-year-old that maybe gets a broken bone playing sports, before you know it, 30 days is an addict. What have you been doing to help educate physicians on proper prescribing, but also maybe de-prescribing these substances?
Those are extremely important issues for physicians. So we've been working very closely with the regulatory colleges and with our educational colleges as well. So there's a number of, as you know, medical bodies in Canada that have sort of different responsibilities for different areas. So we've worked primarily on the production and dissemination of educational tools online and in person across the continuum of medical education. So we need to do a better job of educating medical students when they take their pharmacology courses, so at that foundational level, to understand the potential of opioid addiction, the different types of pain medications that can be used, and other approaches to pain management, as well as things like addiction management. But right now, there's a lot of focus on practicing physicians because of the new formulations of medications, the new types, and getting that information out to them to address exactly the type of issues that you're talking about, which is alternatives to opioid medication in certain circumstances. They can be appropriate in some circumstances, but not others. And then also that de-escalation of dosage as well to get them off of the medication. So we've been working, really hand in glove with these other partners to disseminate those educational products.
Because I heard prescriptions are still up 29% this year for opioids. So is the message actually getting out there? And there's part of the strategy is the criminal element, because it seems most of it's coming from the criminal element, so there needs to be substantial resources there. But from on the ground prevention, is it getting out there? If 29% increase in opioids are this increase the last year, and what more can we do? What advice can you give us?
So clearly there's more to be done, right? And we as a profession have to own that, and we are owning that. We're saying we need to do a better job. As in all of these discussions, it's much more complex on the front line. So if you've got a healthcare practitioner or a primary care doctor who has only 5 or 10 minutes with a patient, it would be much better if they had a long time to sit down and talk through all the different alternatives to pain management. They often have a very compressed period of time, and they feel very pressured to provide a prescription or to renew a prescription instead of talking about the other types of alternatives that are available. It's very they feel under a lot of pressure as well, the frontline physicians, to provide these prescriptions. You have people coming in demanding access to medication, saying, I need this, if I don't get this, I'll go into withdrawal. And they're feeling sort of stuck between a rock and a hard place. And what we're seeing sometimes is, and I see this in my practice, family doctors who are saying, this takes too much of my time, it's too difficult, I feel under pressure from the regulatory authorities on one hand, and my patients and families on the other hand. I'm just not going to prescribe narcotics anymore, and that will be my solution. So they've handled things from their standpoint with their patient population, but those patients just go elsewhere. So we need to do a better job of equipping that group of physicians with the tools that they need to make the proper decisions, as well as the prescribers that need more help and guidance in terms of the proper dosing and de-escalation. So there's no question, there's a lot more work to be done.
Time's up, sorry. Now, Ms. Kwan, we have on our list here that Ms. Malcolmson is the replacement. Are you going to ask the questions? Or?
Yes, I am. I will do the first set, and then Ms. Malcolmson will take the second set.
Okay. Okay. All right. Thank you. Go ahead. We're 7 minutes.
Thank you very much. Let me first off thank all the witnesses for your presentations, in particular in recognition of the first responders and the hard work that you do in our community. Just by way of background, I'm the MP for Vancouver East, to which the downtown east side is located. I have a special appreciation for the first responders there and the community who are hard at work in trying to deal with this ongoing crisis. Back in the 1990s, there was a declaration of a health emergency, and that's when we actually pushed for the first supervised injection facility. Since that time, we have a second round of health emergency, and now with fentanyl and the stats that Mr. Coleman, you presented to us, it is indeed shocking, even for someone who's known the community for a very long time. So to that end, I want to say first off, on the question around harm reduction, it is extremely important, the work that you do, because as we know, dead people don't detox, and that's what we need to get to, and it is a medical health crisis. So on that issue, in terms of going forward, and knowing the crisis that's before us and is going through the entire country, what can the federal government do to address this issue? What action do we need to ensure that the federal government take to work in collaboration with the provincial and municipal levels of government and the NGOs and the community on the ground?
Well, I think first off, we encourage the federal government to really look at this crisis like they would any national disaster, and support the municipalities. The moves to making naloxone available to first responders and primarily to firefighters in BC has been a great first step. Our death rates from overdoses have stabilized in the short term in Vancouver, but unfortunately overdoses, those numbers continue to increase. It should be noted though that naloxone helps, but it's actually first responders on the ground that are saving lives. For a person who's addicted to an opioid or is in an overdose, to walk you through it, the overdose on the opioid, the respiration slow to a point where they stop breathing, which then leads to cardiac arrest and then eventually to death. So it's the support of first responders on the ground. Without the boots on the ground dealing with these overdoses, we're not going to be able to save lives. And municipalities at this point are pretty well taxed on that issue. I think secondly, we need to realize that this is as much a mental health emergency as it is a drug emergency. In the downtown east side, the patients that our members see on a daily basis, almost all of them are dealing with mental health issues. They turn to opioids, to relieve them from the stress of their mental illness. Opioids provide them that relief, that temporary reduction in pain. And many of these people don't have access to proper mental health assistance. So mental health is a very strong point to this. I think we also got to look towards providing mental health strengthening for first responders. it's the first responders day in and day out that they're dealing with these type of emergencies, and as Chris alluded to, there's a lot of pain and suffering that our members feel from having to see this every day. We appreciate the work that the federal government's done so far in identifying that occupational stress injuries and post-traumatic stress disorder is certainly a hot topic issue for first responders that we need a national approach from the federal government to deal with.
Thank you. Thank you very much. I think, would it be fair to say then there's a need to move away from, for example, pilot projects, which has been the historical practice of federal governments come in to do a pilot project on mental health supports. We've had housing that's been developed in the community, and then when the pilot ends, the program ends, and there's no funding anywhere, and then you're going around closing the facility that's been proven to be effective. So do we need ongoing support to do these programs so that we can have an effective long-term result, such as when people talk about treatment and prevention, you actually need to have stabilized housing, you need to have ongoing mental health support for individuals who are faced with those challenges in our community, for example.
It's pretty evident, just walking the streets of the downtown east side, there's members of society crying for help. They don't have the supports that they need, and they're just looking to survive on a day-to-day basis. Being able to provide them long-term assistance, be it with their addiction or with their challenges with housing or their mental wellness, would go a long way in helping their lives.
Okay. I want to turn to you just for a minute. You, Mr. Coleman, mentioned about the impact for first responders, for firefighters on the ground, and I think it's quite striking. I think the words that you used were hopeless and helpless for first responders and the impact for you when you deal with this crisis. So I wonder again on that question, what action can be taken then as well to take care of the first responders, the people who are on the ground in the front lines doing this incredible work to save lives of others? What can we do to ensure that you have the tools that you need to do your job effectively and to also support you in this incredibly challenging situation?
Thanks for the question. As Lee said, recognizing that it's a national problem and helping with the limited municipal resources. I mean, it's we as I've noted, we're quite active on the local scene, trying to work with council and the chief for more staffing, which they get a lot of pushback. So this being a national problem, help from the federal government would certainly help. And just in the short term, it's nothing this committee can do, but I have to say for my men and women down there, they do feel hopeless, as I said, hopeless and abandoned. And they're abandoned by their own leadership. They're abandoned by their own management team, who the brothers and sisters don't feel they're supported. They don't feel, when our chief spoke at a fentanyl crisis meeting 2 weeks ago in Vancouver, he assured council that everything is okay as far as the mental health, and not to worry because we have a great critical incident stress management team. Well, everything's not okay. And it would be nice if they had somebody from the management team come in the hall and not say, "Suck it up," which is a quote from a deputy, but to be there and to help and listen to these brothers and sisters and listen to their stories.
Sorry, but time's up. Dr. Ayalson.
Thank you, Mr. Chair. I'd like to thank the entire panel for showing up and for your service in all these different aspects. I've practiced emergency medicine for almost 20 years, and as much as I agree that prevention is key, it doesn't change the fact that there's an ongoing crisis you have to deal with. Certainly in the emergency department, when all the different problems roll in, you can't just stand there and say, well, this should have been prevented. And I appreciate what as first responders and paramedics have to deal with, because we see the looks in their faces when they bring these patients in. It's horrific. Now, I agree with to support what my colleague Ms. Kwan said about harm reduction, and I know the data on it, how important it is. Dr. Blackmer, you talked about how burdensome the Respect for Communities Act is. What aspects of it in particular are causing problems in preventing more harm reduction strategies?
I mean, there's a number of aspects, particularly the number of hoops that communities need to jump through and the barriers that are put in place in terms of sort of the letters of support and a number of the other procedures that people need to go through. I think we all recognize, obviously, that input from the community is one aspect of that decision-making process, and it's an important aspect, but it's obviously those sort of letters of support from all these, layers and levels are burdensome in a way that outweighs the potential benefit to having input from that community. So that's one example. There are others as well. And I would note, we recognize that the harm reduction is one aspect of a sort of a full approach to this, but it's a very important one. We also know that in communities where these clinics have been established, where there may have been obstacles prior to the establishment. In fact, surveys done afterwards show that in many cases those communities came to see them as being very, very beneficial. So it's it is one. There are a number of aspects to the bill that, while important, provide more obstacles than they need to.
All right, thank you. So, Mr. Bursey, from the pharmacy's point of view, we were talking about the availability of opioids. Manitoba had one of the problems that was noticed through the pharmacy community and the medical community was Tylenol 1s. For background, Tylenol 3s and Tylenol 2s are of course prescription only. Tylenol 3s with 30 milligrams of codeine each. Tylenol 1s with 8 milligrams of codeine apiece are non-prescription. In Manitoba, they were noticing a lot of addicts, because they could get them over the counter, were taking a lot of them, and the amount of Tylenol it took to get high off Tylenol 1s, they were presenting to hospital with liver damage, sometimes needing liver transplants. As well, it turns out that there's a 4-minute YouTube video that shows you how to extract pure codeine from Tylenol 1s. Yeah. So in response to that, Manitoba has made Tylenol 1s prescription only. Would that be a strategy that would be at least somewhat helpful in removing one more source of narcotics from the street?
Yeah, I think it's a good strategy. I know that in my practice we saw a lot of patients seeking Tylenol 1s, and it got to the point where we required a patient assessment by the pharmacist. And if it was an appropriate therapy, for example, for a migraine, abscess tooth infection, then the pharmacist would write a prescription as appropriately, and we would put it on our pharmacy system, and we would be fed into the electronic health records so it could be tracked. And the idea there was that the appropriate patients would be taken care of, and patients that were drug seeking would no longer be able to gain access to it, and we would inform them on alternative therapies such as addiction services. So I can certainly say what we've done in our pharmacy has made a big difference, and I think what Manitoba has done certainly would. I do have concerns with those patients that are getting Tylenol 1s, codeine products for appropriate therapies. If you do schedule it and pharmacists can no longer prescribe it after doing a thorough assessment, I think that could be concerning. But I do think that there's an opportunity there to find solutions that take care of both parties.
Yeah. Oh, to clarify, in Manitoba, pharmacists can prescribe it.
Oh, they can? Okay.
Yeah, they can prescribe it, but they have to do an assessment. They have to actually prescribe it, and it goes on the same electronic medical record that all of the prescriptions go on. So, as you say, it can be tracked.
Yeah, and that's a great solution. And I'm hopeful that more provinces, we can work together to move towards that solution.
Okay, thank you. You made a reference to commercial pill pressers.
Yes.
Now, a very alarming development in Manitoba. Some carfentanil made it into Winnipeg, and I'm familiar with it from my residency. It actually is elephant tranquilizer. In residency, I read when I was doing my toxicology, I read that you would only encounter it if your hospital was near a large animal veterinary facility like a zoo. Because 20 years ago, that's the only place you'd see that, and if there was an accidental exposure there. Times have changed, and it's shown up. And the form that it showed up in Winnipeg, unfortunately, was on paper blotters of the same form that young people will take other drugs like ecstasy and this sort of thing, particularly at raves. And there was nothing on it saying what was in it, but they had carfentanil, and it was a fairly large shipment that the police found. and there have been at least 2 carfentanil overdoses in Winnipeg in the last couple of months. That being said, given that it's such an easy solution, such an easy way to package fentanyl for consumption, would banning commercial pill pressers make that much of a difference, or would it just simply divert more of this to just another form that makes it on the street?
Like we said earlier, I don't think there's a magic bullet that's going to solve all of the problems. But I do think that we're going to have to use multiple different ways to find solutions. I think, regulating pill presses is one solution. I think obviously there's some work to be done with this particular elephant tranquilizer. And I think that, as long as we try to do a multi-pronged approach, then we'll be able to start to make some progress on improving the situation of addiction.
Okay, thank you. Okay, my last question for my colleagues with Vancouver firefighters. Now, again, I agree that it's a Band-Aid, but naloxone is a Band-Aid, but when someone's bleeding, you need the Band-Aid. Now, there are some jurisdictions that have started to use police services for different forms of first response. Some American jurisdictions have actually had police carrying external defibrillators in their cars, calling them on 911 calls to collapsed person. And there is talk of also training police and training them in the use of intranasal naloxone. Right. Would the participation of the police in this, particularly with our new law where police are not automatically giving possession sentences now, right, but for police to participate in this and act in that role, would that be helpful in at least dealing with disaster until we can get it under control?
I think so, and that conversation is taking place at that meeting a couple of weeks ago where our chief said everything's okay. There was a police officer presenting as well to that very subject. So that conversation is happening, and if it's not implemented right now, I'm sure it will be.
That's great to hear. Thank you.
Yeah.
Thank you very much. Now we're going to go to 5-minute rounds, and we're starting with Ms. Harder.
Well, I will first off join my colleagues in saying a very respectful thank you for coming and giving us your time today and sharing your expertise with us. We certainly appreciate it. My first question here, I'm going to direct towards Mr. Blackmer. I recently had a conversation with an Aboriginal teenager in my community who was boasting to me. He was unfamiliar with who I was, and he was boasting to me about the prescription drugs that he would get from his doctor, opioids, and then take those and sell them. And he was telling me that depending on the drug, he would get anywhere from $10 to $25 per pill or per capsule. And so basically, this is actually how this young man lives. And so clearly, he's going to his doctor, he's having these drugs prescribed, and then they're becoming, he's functioning within an illicit market. Now, clearly, his doctor is doing this continuously, and it would appear that there's no accountability. This teenager doesn't take them. So it would be questionable as to whether or not he even needs them. I guess I'm just looking for your thoughts in terms of, is this happening across Canada? Is this a common occurrence? And the second part of that would be, is how would we go about bringing a stop to this type of conduct?
I can't speak to specific statistics around that, but clearly this is a concern across Canada. It's not unique to one jurisdiction, the issue of patients selling prescription drugs, and we've seen this for years. It speaks to some of the challenges that I was alluding to before at that individual patient practitioner level. Having that conversation with the patient, it's very difficult for the practitioner to say, oh, this seems like the kind of person that would go and sell these drugs. You have to understand the patient is presenting. Some of these people are very, very good. If this is their livelihood, they become quite good at this. They present with a lot of pain. They present with a very convincing story. And sometimes they do this to multiple practitioners on the same day. Sometimes it's a primary care provider, but more often it's a walk-in clinic or an emergency room where there's not an established relationship and it's a one-off meeting between that doctor and patient. So there's huge challenges for those healthcare practitioners to really get to the root of some of these problems and to understand how these medications are being used. So there's a number of things that can be put in place to try and mitigate that. Things like prescription monitoring programs so that a doctor can call up in real time the history and say, oh, they were just at the emergency department yesterday and they were prescribed the exact same medications they're asking me for now. More time to have those conversations and to screen for addiction potentials, but also to screen for risk factors in terms of patients who might turn around and sell those drugs. Again, there's no perfect solution to this. It's a number of things that need to be put in place. But it is very challenging for frontline physicians and other healthcare providers to be able to sort of determine in a very sort of rapid sequence of events what will happen to those medications after they're dispensed.
So it would appear to me then that there would be, it would be significantly helpful, make a significant difference, I should say, if we were to implement a national databasing system with regards to the use of prescription drugs. What's being prescribed, why it's being prescribed, how often it's being prescribed, all of those things. Would you agree with that?
Absolutely, that would be hugely helpful, and I think that's one important role that the federal government can play in this area, because it's not just, we know people can cross borders in Canada quite easily, and we know that drug seeking happens across borders as well, and so being able to access that data in real time, it's not enough for a doctor to find out 2 weeks later that the patient that they had seen had been doctor shopping and had multiple prescriptions. That's helpful for sort of future knowledge and changing practice. But in terms of being able to address the issue of the patient in front of them, they need access to all of that information in real time, and we don't have systems like that in place now.
Absolutely. Thank you. And I also, I recently learned that in places in the United States, it's common practice actually for doctors to have a pre-consult before prescribing. So they'll actually bring patients in, sit down, talk to them, have a conversation with regards to why the prescription is being requested, then actually have a separate meeting with that same patient on another occasion to actually do the prescribing. And so it's my understanding that this basically creates a bit of a lag period, if you will. It also, of course, which then allows the doctor to make a good judgment, I guess. But also creates a bit of a loophole for the individuals seeking the opioid. Can you comment on whether or not you feel that this would be helpful in Canada?
I know that there are Canadian physicians that are doing that are having sort of multiple consultations and meetings at different points in time. That also has its challenges. So for someone with severe acute pain, asking them to come in for an appointment now and then saying, I have another appointment in 3 weeks, speaking to sort of the access to primary care and access to physicians, can be really difficult for someone who genuinely needs pain medications at this point. So for some situations, that might be very appropriate, and for others, it might be more challenging.
Time's up.
Thank you.
Thank you.
Thank you. Ms. Sidhu.
Thank you, Mr. Chair. Thank you, all the presenters. My question is to the Vancouver firefighter unions. Is there any particular communities are affected? And what, as you said, it's not a drug issue, it's a mental health issue. So what kind of education, if you can recommend? What kind of resources, like, what is your views about that?
Okay. At risk of oversimplifying, I think it's housing and mental health support. And in the city of Vancouver, I'm sure you're familiar with the housing crisis there. And it gets no easier in the downtown east side when a single-story affordable bakery for the local residents is rezoned to 13 stories of condominiums with Starbucks as an anchor tenant.
Mm-hmm. For mental health issues, any education perspective or any resources, other resources other than that?
I can't speak to that.
To follow up on Chris's point, what a lot of these members of society need is, it starts a lot of times with housing. It's that stability of housing leads to mental stability. Mm-hmm. When you're traveling the street day to day, walking through the cold winter rains in Vancouver, you don't have the opportunity to find mental stability. You're just looking to survive. You're looking for the next place to lay your head in the evening. It's about survival, and if you start with the basic needs of food and shelter, you can move your way up to dealing with mental wellness.
Thank you. And my other question is, I know it's not, it's a temporary, naloxone is a temporary relief. Do you agree with that? Like it's available to remote, rural, northern, and urban communities? So is he accessible?
Is it currently accessible?
Yeah, to all the communities with, if they want it, rural, urban.
Well, I don't know absolutely, but I assumed it was. Yeah, it's.
Okay, there's no barriers.
It's not a prescription drug.
Yeah, but
Right.
there's no barriers. It's easily like.
That's right. Yeah, I mean there's a cost.
Okay. And as we heard, the overprescribing of fentanyl is. Do you think this question is to my CPA? Do you think overprescribing fentanyl is the opioid is contribute to opioid crisis?
I think the vast majority of the fentanyl that's causing this problem is not coming from traditional fentanyl patches that you would see for treating patients such as cancer patients. The majority of this is coming from outside of Canada, tablet form, and it's slipping through, and unfortunately it doesn't take much of fentanyl to be able to provide these people with a euphoria, and the majority of it is coming from external to this country.
Mm-hmm. So as we heard, as the number increased to prescribing these fentanyl, so why this is the increasing number of the in the prescriptions?
There was an increase in the opioid prescriptions. I'm not 100% sure if it's fentanyl. Is it morphine? Is it hydromorphone? I'm not 100% sure on that. Mm-hmm. Personally, from my practice, I have not seen an increase in fentanyl being dispensed, but I can say from talking to law enforcement that we're seeing an increase in synthetic fentanyl from outside of the country. That's primarily where it's coming.
Mm-hmm. Thank you. And can you speak on the drugs? Like we heard from the witnesses who came before, they said telling someone it's a strong drug makes people want it more. They want to look cool. Can you elaborate on that? Is this a fact?
Sorry, could you provide some more context on that, please?
We have a witness before here, and they said telling someone it is a strong drug, the fentanyl, that's why people want to look cool. Is that the fact?
Oh.
Any witness?
I mean, I can certainly say that in my own practice, I've never used the word strong drug for, coming across to a patient. I say it's this is going to provide significant or a lot of pain relief, or it's a medication that we have to be careful with. But when we counsel our patients day in and day out, we want to make sure they're fully educated on the particular medication. Mm-hmm. And if it does seem that it's an inappropriate medication, we consult with physicians and prescribers to make sure that we keep patients safe.
Time's up.
Thank you.
Mr. Weber, see, you have 4 pages of questions there.
Well, to tell you the truth, all 4 pages, they've all been asked already, all these questions. But I do want to focus right now on our first responders and get some more specifics on the administration of the drug naloxone. What exactly has to be done in order to administer it to a patient? Is it an injection into a vein? Is it of course, I hear there's a nasal spray out there now that you can use. Can you just describe how you administer it to your patient?
Sure. Okay. Good question. First, arriving on scene, you'd have to establish that the patient's level of consciousness and determine that there is an overdose, and usually there's good signs because there's needles close or in an alley. Anyway, determine that. A little pain stimuli, see if you can arouse the person, assess and assist the breathing. And then we have a small vial. I'm sorry, I'm not sure of the dose, but there's a small vial that we load the needle with, and it's an intramuscular injection. And sometimes you'd have to do multiple injections, but when the naloxone does take effect, you have a patient in 20 seconds coming out of their high, and often quite upset you've taken their high away.
Very interesting. Basically, an EpiPen that you can just insert and...
Exactly.
Okay.
Au Québec, c'est différent. Nous,
Quebec, it's different. In Quebec, we use nasal spray. We have a vial containing the medication, and then we put we use a spray to administer it through the nostrils, and we have to monitor the patient because, first of all, it's an instant withdrawal, so the patient is very agitated. So we have to control the aggression in the patient, and we have to monitor the person, meaning that we have to use an electrocardiogram because depending on the quantity that's absorbed, after 30 to 40 minutes, the antidote is no longer effective, and if the person is still under the effect of the opioid, it can go right back into it. And we have to transport the patient to the hospital very quickly each and every time.
I just find that in order to administer an EpiPen of the naloxone, you had mentioned, Mr. Leclerc, that there's a 4-hour training program that needs to be done in order to learn how to administer this drug. And I find that surprising that it would take 4 hours to be able to work an EpiPen.
Environ, puisque
Approximately 4 hours, because this drug, normally it takes about 4 hours to get the training.
For interrupting you, I know I have a little bit of time here. I do want to just talk to Mr. Bursey, and you mentioned it a couple times about the drugs coming from outside Canada. We've had other presenters here as well who have indicated they're coming mainly from China. Being the #1 source of illicit drugs in this country. And I do, Mr. Chair, I know that we talked about my motion and bringing that to the table, and I will respectfully do that after our presenters are finished with this session here. But I would like to put forward that motion at that time regarding bringing the Chinese ambassador here as a witness to appear before us to provide evidence as to the measures being taken by his government, the Chinese government, to address the manufacture, distribution, and sale of illicit opioids which are coming here to Canada. So I will wait until after this session here. So, but I do appreciate all of you and your comments here today. Very insightful. Thank you. I assume I'm up on my time.
You actually have 40 seconds left.
40 seconds. Oh boy.
Mr. Kang.
First of all, I would like to thank the stakeholders here for their presentation on bringing us up to speed on this crisis we are facing. And my questions are around the supervised safe injection sites. Dr. Blackmer, how many safe injection sites you think we would need to contain this epidemic, or will they be helpful in the future crisis too?
I don't think we have information on the exact number that are needed. I know different municipalities have looked at their own individual needs. Certainly here in Ottawa, we've had a number of conversations that perhaps more than one would be appropriate for our population. They've done some analyses in cities like Toronto and Montreal and other urban locations as well. Again, I think the point to understand with this is that this is one part of an overall strategy to combat opioid addiction is the harm reduction piece, which would include the supervised injection sites. So it's not a panacea for this entire issue as we've heard before, but it's one aspect that deserves some further attention and I think support as well.
So what other avenues we could explore in your opinion to alleviate this crisis? other than
Other than harm reduction?
yeah.
Well, there's a number of pillars. So there's the prevention piece, which we've heard about, and education for physicians and other care providers, and looking at alternatives to different types of pain management initiatives and interventions. There's the treatment for patients who are addicted. So whether that's detox, which does not work very well for narcotic and opioid addictions, or whether that's substitution therapy with things like Suboxone. And then there's the prescription monitoring programs as well, which is a very important aspect of this. So it's really, again, it's addressing any one of these issues will lead to unintended consequences, as we've already heard. So we need a national strategy, and we've heard a little bit about what that could look like, that will address all of these types of issues, whether it's the availability of naloxone at the front line, or better education of care providers, or harm reduction strategies. It needs to be multifaceted.
Okay, there was a pilot project carried out at supervised site in Vancouver that provided drug users with the option of testing their drugs for fentanyl, and found 86% of the drugs tested contained fentanyl. And when Dr. Bonnie Henry, Deputy Provincial Health Officer of British Columbia, appeared before this committee October 6th, she noted that there are legislative barriers that prevent individuals from checking their drugs for fentanyl, and that exemption would need to be made under the Controlled Drug Substance Act to allow this practice. So in your opinion, should legislative barriers be addressed to facilitate individuals test their own drugs for fentanyl or possibly other substances? If yes, how should the drug test kits be made available to people who use drugs? And you think this will help alleviate the overdose problem?
Again, I think that would be one part of an overall strategy, to be able to identify those substances and act accordingly. I think many Canadians have been quite shocked to hear some of those statistics, that fentanyl is making its way into other substances through this means. We've heard about importation from foreign countries. I think testing these substances makes a lot of sense, but again, as one part of an overall strategy.
Thank you, sir. And my next question is to Mr. Bershey. What role do the pharmacists play or can play in identifying, treating individuals with substance use disorders?
I didn't catch the last part that you said, sir.
Substance use disorders. What role the pharmacist can play?
Well, I think pharmacists often are the eyes and ears of physicians on the front lines. We see patients, especially addiction patients, or patients that are receiving pain medications many times throughout the year. In New Brunswick, we see an average, the average number of visits by a New Brunswicker to a pharmacist is 16 times a year. So it's a great opportunity for identifying and collaborating with our physicians, with our addiction programs, to find solutions to make sure that these patients that are in the throes of addiction, that they can get treatment. So I think pharmacists play a key role in collaborating with other health professionals.
Thank you, sir.
Ms. Malcolmson, thank you for coming.
Thank you, Chair. I'm Sheila Malcolmson. I'm a Member of Parliament for Nanaimo Ladysmith. We have the sad honour of having more deaths per capita to drug overdose than anywhere else in British Columbia since 2008. So this has been happening for some time. The BC coroner just last month said that Vancouver Island Health Authority, you think of this beautiful island, paradise, rural area, we have had the largest increase in opioid deaths, 135% increase from last year, and we're the highest rate of overdose deaths in British Columbia. So I appreciate the work that the gentlemen and sisters are doing on the front line, and all of the advocacy that you're taking through all of your organizations. Mr. Emberley, you were quoted last year saying this is really a disaster that's happening all across Canada. And we're hearing that again and again here. In your view, is the opioid overdose crisis a national emergency?
I believe it is. At first we were hearing it in pockets. We were hearing it as a problem in Vancouver and maybe in the prairies as well. But every community has been affected by this. And working in a pharmacy, we see it. I see it in Ottawa, where I work in the West End, that there's a certain population that has been profoundly affected by this, and we see people getting into trouble with medication. We see people coming in early for their opioid prescriptions, and it's a sense that they're getting out of control with their own personal use of these medications. So it is definitely a national problem that no community is unaffected, and for that reason, I believe we have to treat it as a national crisis.
Thank you, Mr. Blackmer. We've really appreciate the advocacy that your group is doing. I note that the Government of Ontario recently appointed an overdose coordinator. This is the first province that's taken that position to put someone in the role of developing surveillance and reporting systems, gather data on overdose deaths, and inform decisions about patient care. Do you believe that the federal government should follow suit by tasking our Chief Public Health Officer with coordinating a national response to the opioid overdose crisis?
Absolutely. And I think there's a lot that the federal government can learn from what's being done at the provincial level. You alluded to whether or not this is a national emergency. I think if we look at provinces like British Columbia, where they've declared a provincial state of emergency, they've done that primarily to have access to some data that they would not otherwise have. So not just deaths by overdose, but the actual number of overdoses. And I think there's a lot, again, that the federal government can learn by looking at what some of the individual provinces have done and instituted, and then try and roll that out at the national level.
Time's up. Sorry. And that concludes our testimony today, and I really want to thank the presenters for their contribution here. You're all been closely involved with this issue, and you've helped us a lot. And your testimony will be reflected in our report. So I want to thank you very, very much for coming. And to the committee, we have some committee business to do, so we're going to take just a 2-minute break, and then we'll reconvene to deal with some motions. Okay. We could all reconvene. Now, we have some motions to deal with, and when we started this study, we agreed that it would be public and broadcast, but this is committee business, and we have to have the agreement of committee whether it's going to continue to be public and broadcast, or is it going to be in camera, because it's committee business. I know Mr. Weber, the mover, prefers public. So, Mr. Weber.
Thank you, Mr. Chair.
But this discussion is just whether we're going to stay in camera or.
Yes, well, no, I would like it to be known publicly that I would like to put this motion on the table. The fact that we've had numerous presenters here indicating to us that these illicit drugs are a problem, and they mainly are coming from China, and that we've had the Canadian Border Services here, we've had the RCMP here, and they've all indicated that the problem is China and the illicit drugs coming from there. And we're talking super drugs, super fentanyl, carfentanil drugs, which could wipe out the population of Canada with some of the shipments that are coming here. So I do want to put the motion on the table right now, Mr. Chair, that pursuant to Standing Order 108 Sub 2, the committee calls upon His Excellency, Mr., and pardon my pronunciation, Mr. Zhao He Lu. He's the ambassador for the People's Republic of China, to appear before this committee to provide evidence as to the measures being taken by his government to address the manufacture, distribution, and sale of illicit opioids into Canada. So that would be my motion, Mr. Chair.
All right. Do we have a speakers list? Yes. Mr. Oliver.
Thank you, Mr. Chair. Without discussing the merits of the motion, in fact, I think we should have stayed on the topic that you asked us to stick on. Are we going in camera or not? So regardless of the merits of the motion, I believe it is committee's practice that we discuss witnesses and to our committee as in camera, and I would request that we moved in camera immediately.
Mr. Khan.
I echo Mr. Oliver's words. Thank you.
Dr. Carey.
I would disagree. I'm in favor we can go into camera for discussing our witnesses, and that part of business, I think that's customary. But for the motion, I think we can do the motion and the vote on it publicly. I'm willing to. I think my colleague's willing to put the question right away.
I did put the question right away.
All right. All in favor of going in camera, say aye. All opposed? Okay, we're going in camera.
Sir, I think we were very.
Let's do it again. All in favor of going? All in favor of in camera? 1, 2, 3, 4, 5. All opposed? 1, 2, 3, 4. So we're going in camera. A recorded vote.
They've already voted on now, so.
It's already voted, so we can't do it. All right, so we're going in camera.